Hello, Rhys.
You're right.
Hello, everyone. I'm talking to Rhys today. So Rhys is a dear colleague of mine. I worked with him a lot over the past years. He's worked in multiple healthcare settings that include sexual health and A&E, and both of those places do get quite a lot of chemsex patients. So he's a kind of perfect guy to talk to about the presentations in those kind of settings. But particularly today, we're talking about A&E. So Rhys, hello, and do you want to tell us an introduction about yourself and where you are, and mostly I want to know what made you want to be a nurse?
So hi, yeah, I'm Rhys. I'm a nurse. I have, as you said, David, I've got a background. I used to work in A&E. I used to work in sexual health. I currently work in as a research nurse, working on a mix of studies related to emergency care, trauma, and due to the pandemic, COVID. The reason why I wanted to be a nurse, what a fantastic question. I feel when I was a kid, I wanted to do a job that was going to benefit a cause, that I was going to help someone. I never wanted to sort of make money for the man. I just thought a job where I could benefit a cause. So, and when I trained to be a nurse in Wales, you got paid to do it. You had a bursary, you got, so it was kind of much more affordable for me to do it. I could move out of home. I could afford to move to London straight away. And so it kind of just made the most sense of wanting to leave home and also do a job where I was helping people.
I can testify to the good. I know that you really well, and your big heart is why you do all of this stuff. That's why it's really nice to see you today too. I wish I saw more of you.
Well, I'm going to be blushing this entire thing. I can feel it.
We're only at the beginning. So I've got some questions for you because, yeah, sadly, chemsex is a lot of fun for a lot of people, but a lot of the time people end up in A&E departments more often than I would like them to. I'm sure they too. And I think some people, yeah, well, you've been in that environment. So you have worked as a gum nurse and in a chemsex clinic. So you're familiar with chemsex culture and the chemsex patients even before you started working in A&E. Can you tell me what kinds of chemsex presentations you saw while you were there in A&E?
So it's quite interesting actually, because my sexual health experience punctured, it was between my A&E experience as a staff nurse and now as a research nurse where I'm in A&E quite a lot. So I have this kind of before and after experience in the chemsex clinic, which was really helpful on a personal level for like reflective practice. The kind of attendances I saw, I saw the same things before I worked in sexual health and after I worked in sexual health. The main kind of things that we were seeing quite regularly when I was in A&E was drug-induced psychosis, and obviously quite poignantly crystal meth-induced psychosis was quite a common one. GHB overdose, another very kind of poignant example. However, I think there's actually something to be said about the more subtle and maybe the less kind of high pressure emergency things. So something like attendances for people seeking PEP if they've had a exposure to HIV, sexual assault, that is an attendance that we see quite a lot in A&E, and not necessarily as part of the chemsex scene, it wasn't necessarily its own presentation, but was something, you attended with a GHB overdose and then you'd also disclose that you've been sexually assaulted. And then another one that kind of slips under the radar is things like injecting kind of incidents and accidents. You can go on to develop kind of localized skin infections and like collections of infection called an abscess. So those were things that you'd kind of regularly see in the A&E department.
Yeah, see, I'm very aware of the really common ones, like meth psychosis. I would say that the people that meth psychosis is really common. And what does that look like when someone is experiencing psychosis in your A&E department?
So it can vary kind of wildly, and it depends on maybe the cause of the psychosis, because psychosis isn't always drug induced. It can be induced by sort of pre-existing mental health conditions and other such things. Now, a psychotic patient who's attending the department, they're going to be, we would sort of use the term like lacking capacity. So they may not necessarily have insight into their presentation or insight into the kind of severity of what's going on. They may not sort of air quote, be in touch with reality. They might think that they're being chased, or that someone's out to get them, or they might believe something that isn't true, essentially. They might also be presenting quite erratically, so might be presenting as potentially aggressively, kind of all over the place, quite hard to keep safe. If there's lots of other people around, or maybe objects, you can maybe get hit. And a psychotic patient also might kind of appear a bit sort of withdrawn and a bit scared. I think sometimes it's easy to concentrate on the patients who are loud and physically draw your attention, when actually there might be someone just sliding under the radar quietly in the corner who you might not have picked up on. And then another big kind of alarm bell in terms of a psychosis patient is someone who maybe is trying to leave. We want to make sure that someone has the capacity to make that decision, and are safe if they do. And if you're kind of in the middle of a psychotic episode, it's unlikely to be the case.
Right, a couple of things really interest me there. So that one thing that I've heard before, I've observed before, is that I hope there's nothing incorrect about what I'm saying here, but it seems like the obvious thing when people are experiencing drug-induced psychosis, it can often seem, especially in regard to men more than women, violent, outwardly violent, aggressive, harm towards others, and aggressive and kind of frightening. There is a saying that one of our female volunteers told me once, which is when male people experience fear, it's sometimes outward and violent, and when women experience fear, it's more internal, so harm toward themselves rather than harm towards others. And I've always noticed with our gay patients who are doing chemsex that when they're presenting in terrible fear and psychosis, it's rarely violent. It's almost always hurt themselves, looking very panicked, but quiet and alone, and they're more likely to hurt themselves than anywhere else. And again, not always trusting A&E departments. Do you notice that too in A&E? In
terms of not trusting A&E departments?
No. Well, yeah, that too, but do you see violent gay men experiencing chemsex psychosis?
I think it's sort of a mix. I've experienced, I have experienced violence by LGBT people. I've verbal and physical, and I've also experienced violence by someone we assume to be a straight man or a straight woman. It is a genuine, quite a big mix.
I guess you don't get in those emergency environments, you're not always checking people's sexuality and stuff like that.
No, it's not necessarily the first question, no. But in terms of, what was your second point? I'm really sorry, it slipped my mind.
Yeah, I don't know either. I'm just round it. I was curious about how do you make someone feel safe? Because I think obviously you've got to keep them alive, but again, if they want to leave because they don't trust you, I guess what you try to do is make them feel safe. How do you do that?
Well, if someone's trying to leave and it's not safe for them to do so, it's a very individual case-by-case decision, and there are kind of different options and different routes you can go down. You can do something called a deprivation of liberties. You can, you know, if someone is a danger to themselves or others, you can you know, physically restrain temporarily, and use medicines like sedative drugs to make someone relax. Those are kind of always last options, and I think actually what you just said about making people feel safe is really kind of poignant. I think sometimes it's really difficult in an A&E department to, or in like an unplanned attendances kind of environment, to make people feel safe. And I think I mean, you saw me at work, you know, I always believed in the little things, the smiling, the hello, the welcoming kind of face and attitude and body language. And I always think, you know, before you've said one word to a patient, you've said a million things to them, and the conversation's virtually already dictated how it's going to go. And so I think more than anything you can say, I think just the way you present yourself and the kind of kindness that you show maybe is more important than kind of anything else in terms of making someone feel welcome and safe and that they're in the right place.
Yeah, beautifully put. And I do agree. I've spoken to loads of people that were terrified to go to A&E in the first place But when they got there, it was an individual person that made them calm down quite often, and not so much medical intervention that caused it. It was usually a human being. That, I have to say that lots of people watching this will be from all over the world. And in London, where we're talking about, there's lots of LGBT awareness. There's even chemsex awareness. There's meth psychosis awareness. There's G-overdose awareness. There's a whole lot of cities in the world where A&E departments aren't really that clued up on all of that. But I think the message, if you agree with me, would be if you do feel like you're in danger with anything and if you feel it's urgent, do go to A&E. Even if they're unaware of some cultural issues, they know how to save a life, and they're usually kind people.
Yeah. And I think something to sort of touch on, something you've kind of started to say there, David, you know, if you have gone to an A&E department and you don't think that you've been given the kind of appropriate care that you should have been, as you said, people around the world are watching this, but in the UK, you know, you have the right to complain. And if you don't think it's safe to complain in that moment, you don't want to complain in that moment to the staff, we have a service at every single hospital and every single trust in the UK called PALS, PALS, Patient Advice and Liaison Service. And they are someone to contact in terms of if you didn't feel like your attendance was, if you don't think that you were given the care that you deserve, that's a way to kind of escalate your concern and seek support and help.
I imagine that a lot of hospitals in the world, I would like to reassure people that I really do believe that nearly all A&E departments in the world have really skilled, brilliant people. And even if they are culturally unaware or even a little bit homophobic or sex phobic or don't like the fact that you've been doing drugs and having sex, they still know how to save your life and provide care. So, I mean, yeah, there's usually follow-up things if you feel like the care wasn't culturally sensitive afterwards, but don't let that prevent you from going there. You know, they're really good at saving lives.
Please attend A&E if you think your health is in danger.
Yes, and everyone in every A&E department is going to be as lovely and friendly as Rhys is.
Oh, there we go.
Tell me about, so the other most common presentation would be a G overdose. Someone's taken too much G. So a lot of people think that when you take too much GHB, you just fall unconscious. It's not quite like that, is that? There's a period when they're over intoxicated, when they're in your A&E department. What does that look like?
Again, it's very patient dependent and very case dependent, but the kind of classic sort of thoughts that pop into your brain are the young man maybe who's running around grabbing people, trying to kiss you on the cheeks. I mean, I remember there was one patient that me and a colleague looked after, one of our registrars, one of our senior doctors even, and we had to sort of physically hold the patient from each side and walk him from our assessment area to our kind of treatment area because, you know, he was trying to kiss us and he was trying to climb on top of us and very hypersexual. Again, this is a kind of, what am I trying to say? It's an outlier. It's an extreme example. However, these patients do tend to be quite manic, quite all over the place, very animated and kind of wanting to engage with you and talking to you. And but the scary thing, as you've already started to say, David, is that this chap that I was looking after, he managed to kind of get out of our grasp, and as he was running down the corridor, he started to slowly lose consciousness, and he kind of had to get rushed to emergency care to kind of keep him kind of safe. So, you know, it's easy to be distracted by the kind of the manic, the loud, the attention, not attention seeking, that's not the word, but the behavior that draws your attention, when actually there could be something a bit more life-threatening just down the road.
Yeah, and again, the staff in A&E know how to look out for that and prioritize that.
Yes.
Yeah, and I think it's hard as a harm reduction worker to give advice to people about G because lots of people say, yeah, but my friend passes out all the time. He over in the corner of the sex party. We don't have to rush him to A&E. But we don't know when a person who's asleep on G is going to wake up or not. There's no way to actually tell that person can fall asleep and he'll be fine, and that person can fall asleep and he won't. We just can't tell. So if you are with someone who has passed out on G, I think we recommend you to look at their breathing. If their breathing is irregular at any time, or if you actually can't wake them up aggressively, call an ambulance or send them to A&E. Would you agree with that?
I would, yeah, I always think have a very low threshold for seeking emergency care and emergency help. If you, especially if you're already high, you know, it can be difficult to sort of remain calm in these moments, and it can be difficult to remember all the bits of advice. So if you're having someone who's losing consciousness, at that point, I would be preparing to, you know, call an ambulance and to get some help if someone's starting to lose consciousness.
Because sometimes people don't wake up from that. So you would have had people present who are really, really high, behaving in that way, because a lot of people, when they're on the drug, they're enjoying a sexually disinhibited high. So when they go into that overdose moment, they're in a very primal, sexy, horny place. That's why they can behave that way. But even though that can seem fun, it can seem like that person is really up for sex and asking for it, but that is a person who isn't competent to make decisions. It is a person that might need to be taken to A&E. And yet in some cases, they're observed and the high passes and they're okay, and sometimes they don't.
And I think that's why I always think have a low threshold, because there's no way to, you know, even in an A&E department, it can be very difficult to tell. We have to manage, every patient gets managed appropriately and every patient gets managed differently. But ultimately we have to protect your airway. And what GHB can do is it can, it's what we call a respiratory suppressant, or what that basically means is it's slowing your breathing down and stopping your body's drive to breathe. It's a really subtle difference that between someone who's asleep and someone who is kind of overdosing and is becoming very, very unwell. So please, if someone's getting to that position, you need to call an ambulance and get help.
Now, crystal meth overdoses are actually quite rare. So in the Americas, where a lot of crystal meth is laced or adulterated with an opiate, which causes a lot of overdoses, actual crystal meth itself doesn't cause a lot of overdoses. But when a person is too high or has taken too much crystal meth, it can be potentially dangerous, and those symptoms can seem like a panic attack as well. So if someone is on chems and having a panic attack, do you think A&E is the right place for them to go?
Yeah, I would recommend if again, it's very it's difficult to say, because again, it's definitely a case-by-case basis, and you know, I can imagine if someone's panicking, you know, being forced to, you know, being dragged to an A&E department might make that kind of situation worse. But then it's all about kind of balancing your pros and risks.
Maybe I'll put it this way: if someone is at home and they're saying, I think I'm having a panic attack, but I don't want to waste A&E's time. I don't want to go there because it might just be a panic attack and I don't want to waste their time. I'm not worthy of that support. What do you say to them?
You're always worthy of that support, and you are 100% not wasting our time. We have, yes, A&E is often a very busy environment, but we want to know who's ill. We will assess you, and if we do not believe, if you are not exhibiting any signs to say that you are really unwell, you'll be discharged. You won't have wasted our time. That's what the service is there for. If you think you're having complications following chems use or following drug use, come to A&E. We'll tell you if you're not.
Good. You're a good example of this too, I think, Rhys, because I like you do, I've got lots of friends who are staff in A&E departments, go drinking with them sometimes. Sometimes they complain about the hard day they've had. But one thing I can say about every single A&E staff member I've met around the world is that they never feel like someone presenting there is wasting their time. They know the very importance of the high importance of their job, and they never shame or ridicule a person for wasting their time. I've never heard anyone do that.
No, and again, I think there might be some perception that, you know, maybe there's a perception that A&E nurses, you know, that you might have felt ridiculed or that you might have felt shamed about your attendance. And again, if that's the case, PALS is your service to speak to. They can help you through that, and they can help you talk to the department and work out what's going on. Sometimes it's a really simple misunderstanding. I might have been laughing about my, I don't know, stub my toe, might be having a joke about it. Oh, that's a bad example, isn't it? I might be laughing. Yeah. I might be laughing about something, and it might be outside your room, and you might have, it just crossed wires, isn't it? You know, it's so easy to do. And so again, if you think that there if you feel like you've been treated unfairly, please contact PALS. However, please know that A&E nurses, we've seen it all. You are not, you're worthy of attending the department and making sure that you're safe, and you're also worthy of not feeling ashamed of doing that. So please come to A&E.
Good. And a lot of people do feel ashamed. I mean, this is just from a legacy of societal homophobia, of gay sex being disgusting, of it being a diseased thing, a shameful thing, a naughty thing, an illegal thing, an immoral thing, an irreligious thing. People do feel like ashamed just because they're having sex with a person, more than one person, with sex toys, just the bum sex. They do carry this ridiculous, I don't say ridiculous, this unnecessary but very, very relevant shame. And sometimes it can prevent them to go to A&E. But like you say, I want to just repeat what you say. A&E workers have seen it all, and they love saving lives and keeping people safe. And that's much more important than any cultural obstacles they might experience. Please do go to A&E if you need to. Rhys, I read some research, not quite recently, that said that meth psychosis accounts for 5% of all A&E presentations in London. Which that's quite a lot if you consider that meth is really only used by gay men in London. And so it's a very small number of meth anyway, and not all gay men are using meth. So it's actually a tiny amount of meth use in London, but accounting for such a large amount of A&E presentations. Do you feel that there are disproportionate numbers of gay men needing A&E care because of Chems?
In terms of attendances as a whole, yeah, and actually we've kind of got some data to back that up from the department that I work in. I'm a research nurse, got to love a bit of data.
Nearly every conversation with you has got some brilliant data in it. I'm glad to hear it.
Always got to carry the data. So I'm really lucky to be working with an A&E consultant who is really passionate about toxicology. And he has established a relationship with a European-wide drug network sort of database, and we supply them data about our drug-related attendances, and they use it to sort of track trends and publish data and essentially try and improve patient care. And so from January and February this year, we had, and just to be clear, the data system we're using to capture isn't 100% perfect. So these might not be 100% accurate, but we can say with like rough certainty that in January of this year, we had 62 drug-related attendances to our A&E department, and 20 of which were GHB or crystal meth related. There were 13 GHB related attendances, 15 crystal meth related attendances. 8 of those had with the same sort of attendance, so crystal meth and GHB. And then there was 3 of those attendances also had a mix of other drugs as well. So if you look at that month alone, that's a third of drug-related attendances were GHB and or crystal meth related. And again, so similar.
Most likely gay men, right?
Yeah, most likely gay men. And again, I haven't really picked through that data. And you know, we do see women attending with GHB overdose, and we do see with crystal meth use. But again, I sadly don't have the kind of gender breakdown or sexuality breakdown. But in February of this year as well, there were 64 drug-related attendances to our A&E department, 16 of which had taken crystal meth and or G. There was a 2 kind of crossover, so 2 people had taken both, and 4 of those people had also taken another drug alongside. There is a small bias in this data that it's patient reported, so they might not they might not be entirely truthful. But you know, if we can say roughly between in January and February, it was between roughly, I don't know, 1/4 and 1/3 of attendances were GHB or crystal meth related.
I'm here. You're a little, because I'm 55 years old. You're a lot younger than me. I remember a time when gay men in my city had never heard of crystal meth, had never heard of G. We used loads of ecstasy, loads of sort of low harm speed. We used a load of alcohol. We used a load of MDMA, and you know, there weren't a lot of A&E presentations then. There really weren't. You know, if I was talking to someone of my generation 30 years ago, he'd be saying, gay men are out there doing loads of drugs, but they're not having many harms about it. They're out having fun and hugging each other and having lots of sex and loving. Now it's a third of A&E presentations, and that does upset me a lot.
Drug-related A&E presentations.
Yeah.
But yeah, it's kind of shocking, isn't it? And it's important that we're kind of aware of. I didn't really have a statement for the end of that. We might have to cut that out. Sorry.
No, we'll leave it in because I'm speechless too. It's such large numbers of our community are struggling like this, and really, they're just trying to find sex and love and connection and pleasure of a night out on Grindr. It's not. It shouldn't be that dangerous to find those things or to enjoy those things. It should be so hard. Anyway, thank you for the data guy. Gay men can be very ashamed. We've covered this already. I've got a question here, but I don't want to ask it anymore because we've kind of covered about the shame of walking to A&E, but you covered that kind of nicely. Sometimes when a person wakes up after G, they find themselves in A&E, and there's quite a lot of it's quite a shock. Back in about 20 years ago, when we were still sort of learning about G and it wasn't really well understood, there was quite a lot of G overdoses happening in nightclubs, in Vauxhall mostly. And a lot of them were being taken in very large numbers to A&E departments, by the ambulances. And at the time, there were a lot of people who were coming back to the nightclub after they'd been in A&E. So do people actually, when they wake up from a high, are they surprised to find themselves in A&E sometimes? And how do they, what is that like when they wake up and they're just in A&E?
Yeah, so again, it is a real mixed bag, but you definitely do have patients who are surprised to find themselves in A&E. You do have patients who, when you have sort of gone under on G, you're not going to necessarily remember what's happened. And so you might be going to the bathroom at the party and then you wake up in your A&E department. That must be really scary and like disorienting, and must almost sort of feel threatening. You're in this like bright, very sudden environment. You maybe got a nurse standing over you or a doctor kind of there. It must kind of be scary, yeah. But back to your point, yes, I can think of a few examples where the person they've gone back to the party or gone back to the club or whatever.
Yeah, and a lot of them are very angry with their friends for doing it there, and I can imagine it is very disconcerting and upsetting. But I would like to suggest that it is dangerous, that G overdose. If you're unconscious on G, it is potentially dangerous, and we do have about, I can't remember the number now, but we have about 2 or 3 deaths a month in London from GHB. And that's too much. And these are people who just got a little high and thought, I just need to take a nap because I'm too high, and that's how. And then they died. So I do want to stress the danger of G, and do go to A&E. And if you've got a friend who's passing out, do call A&E. You could be saving a life. We talked before. Yeah.
To add to that, David, sorry, it's something I used to say quite a lot in the sexual health clinic was, and you kind of translate it to that moment is when assessing people's chems use and drug use, I used to ask kind of regularly. Or sort of say, hey, where is your boundary where you think your drug use has gone from manageable to problematic? Where is your sort of boundary? And often people hadn't necessarily thought of that. And I'd sort of say, no one goes into using chems or drugs with the hope or the plan to develop a dependency or develop problematic use. And it could just be anyone that, you don't know if that's going to be you or not. And I think that's kind of translatable actually to whether you could become seriously unwell after taking G. You didn't do anything wrong. You're not special. It can be anyone. The person who died from a G overdose isn't a bad person, or they didn't do anything necessarily wrong. And, it could be anyone, which is why it's really important to have that low threshold to call an ambulance and go to an A&E department for help.
Yeah, very true. And to add to that, there is a lot of people think that the people who die from G is because they didn't know how to dose on the G. But actually what we're seeing is the people who are dying from G are very experienced long-term users of G who know the dangers, know how to dose correctly, know about the right time intervals, and yet it's going wrong for them too. So it is a dangerous drug. You can know a great deal, always learn about how to dose correctly and how to have the right time intervals between each dose. Always dose yourself. But no matter how expert you are at it, experts do die from G-overdoses too. So if you or someone you know is passing out, get to A&E, because there are brilliant people like Rhys who are going to save your life. We were talking before, Rhys, about cultural awareness about, say, chemsex and stuff. I mean, if I've been at a chemsex party and I've had loads of dildos up my ass and I'm still dripping with a little bit of lube, but I suddenly wake up in an A&E, I'm terrified that these assuming heterosexual workers there are going to hate what I've been doing and treat me badly because they're disgusted by what I was doing. That's life of being gay for a lot of people. And it's why people don't call ambulances out to chemsex environments or places where they've got a shag over on chems. My question for you is, do staff in A&E need to be culturally aware of these things?
Yeah, I think it's really important to. I think it's really important that that, like any sort of group in society, you know, if you are of a certain population, there might be factors that predispose you to diabetes, and it's important that we're aware of these things and how to kind of tailor care and support these patients. And it's no different if you've been knocked off a bike, whether you've got an infection or whether you've attended because you have you've used chems. I think it is important for A&E teams to be aware of the kind of culture that surrounds chems, so you can tailor and personalize the care you're delivering to that patient, and making sure that it's easy. You know, obviously you want to save a life, and if that's the priority, if that person requires that care, but sometimes that person just requires you signposting them to somewhere they can have a more in-depth conversation, or sometimes just making sure that person is armed with a bit more knowledge, and maybe armed with something that could help them in the future. And I think, as you said, the best way to do that is knowing your population and knowing how to tailor your care towards them.
Well, I from personal experience, and you know, it's about me, in my long time ago when I was looking for help from chemsex, I was being referred by healthcare workers to traditional heroin support clinics. And they didn't understand Grindr. They didn't understand my HIV risks. They didn't understand stigma of HIV in my bedroom. They didn't understand Grindr or my hookup culture. They didn't understand the drugs that I was using, but they thought they were referring me to the right place. So there are a lot of A&E departments that get training in the culture of heroin use. They understand that heroin is often associated with trauma and self-medication of trauma. They understand that it's about street homelessness and poverty and crime quite a lot of the time, and estrangement from families and structure and boundaries. Chemsex is not about that. Chemsex culture is about gay sex. And you, like me, believed quite urgently that A&E staff should get trained in this. And you did, in fact, arrange some chemsex training for some A&Es in London. Thank you.
Yes, we did as well. I've just remembered we went to an A&E department in London. I forgot about that. Yeah. So we did some training together, David. Of course, we did in a hospital in London for the team there to help them get to know the kind of culture and chems. And that was before my sexual health experience. Oh no, that was during my sexual health experience. Excuse me. And then since starting where I currently work, I don't work in the A&E department, but I work very closely with the A&E department, and they're a really incredible bunch. And I've got some fantastic consultants who know about toxicology. We've got some really good LGBT representation in our department. And independent of me, they have developed some crystal meth and chemsex specific written guidance for patients who attend, so a patient can walk away, maybe they'll forget what you told them, but at least they've got it in their pocket. And I've delivered some training which is very much a casual conversation around my experiences in the chemsex clinic, and trying to relay the experiences of the patients that I've met in the clinic to the A&E team. Yeah.
I do know many chemsex advisors around the world and in London who have had somebody sitting in front of them and they're saying, the only reason I'm here is because when I came out of A&E, I found this in my pocket, and that's why I'm here. That's
I think it's really kind of poignant, because, you know, my experience when I was in the clinic was that patients who were, the people who wanted help with chems, whether emergency care or chemsex support, they're essentially only ever really attending two services. It's A&E or chemsex. And if one of those services aren't perfectly positioned and trained up and ready to go, then it's not going to work. So I think it's important that A&E teams really do have a robust kind of knowledge and understanding of the culture and chemsex.
You've had the, forgive me, you've had the privilege of working in London in this sector, where there is great chemsex awareness, not only in gay communities, but in healthcare settings. I mean, there's, and in culture, you know, there's chemsex musicals, and there's chemsex plays, and there's chemsex drag queens, and there's chemsex support services, and there's LGBT chemsex drug charities, and there's sexual health clinics that all understand it, and A&E staff that understand it. But a lot of people in the world don't. So as someone who's had the privilege of knowing good partnership work and interdepartment working, do you recommend that for other cities in the world?
Yes. Oh gosh, yes. As you said, we're so lucky in London to have, I always think that help, it can't be kind of one-faced. It can't just be an A&E department is trained in chemsex. You also need to have the other network, the community support, the humor, the drag queens, the plays, the conversation needs to continue outside of one place. And I think that, as you said, London, we're very lucky, but if you're in a city where the chemsex support, or, the culture and chemsex isn't as open and conversational, there's a way to find your community.
And I don't want to put you on the spot, but if I was going to ask you to bullet point, what did you feel the staff needed when you were doing the training for the staff in A&E? What were the main things you think they needed to understand or learn most of all?
You sort of touched on it really well earlier. The big kind of focus of what I talk about is understanding the difference between the needs of, say, a 17-year-old who's had a bad reaction to ecstasy, and she's a heterosexual girl at a party, and the kind of the drives, the wants, and the problems that drug is medicating. Why is that happening? And as you said earlier with heroin, why does heroin happen to these people? So I try and illustrate and make sure that people are aware, why do people use chems, and why do the chems what problem do the chems medicate, and why are they an attractive drug to use? And I just want to make sure that people, I felt like my position when I worked in the clinic with you, David, was very kind of relatively unique. I don't think there was many people who worked in a clinic quite like we did, and I think it was interesting to see it from my A&E perspective as well. And I almost wish that I'd had that knowledge and experience. I wish someone had come and talked to me about it when I was an A&E nurse in the way that I tell people. Sounds very conceited, but I think I just think it's I think it can only help the patients, and it can only help the people who need it. So
we're all human, and if I didn't work in the drugs world, I might not be able to empathize with why a heroin user would keep on doing heroin, even though it meant that they've got money to sleep in a shelter tonight or money to do drugs and sleep on the street, and they choose that. And I used to wonder, why would they do something that seems illogical to me? And I think a lot of people that do drugs, particularly in chemsex, so they're scared that people in service departments are going to go, why do they do this gay sex with these drugs that was going to end them in A&E? Why do they keep doing that? And there is a reason why. It is really complicated, and you understand that, and you wanted your staff to understand that. I think
I can imagine it could be really easy to be, it's a really busy A&E department, and someone's taking up a lot of resources. What I don't want is a patient to go to an A&E department and feel that they've been treated unfairly or discriminated against. And I think the best way to counter against that is making sure that people are informed. Knowledge is power. Making sure the A&E team know why people might, what the culture is around chems use, so that you can tailor your care and you can make people feel welcome. Making sure they understand the terms. Someone might be saying, I use Tina. I remember there was a patient, David, we had together who hadn't realized they were using crystal meth. for, I think, the last year. They had no clue what it was. They thought it was just Tina. And so making sure that people are aware of the kind of red flags and triggers to make sure they can identify and appropriately help and support patients. But again, making sure that you are welcoming patients in and making sure that they do want to attend if they need to.
Right. There might be patients walking into A&E departments to say, I slammed this, and the A&E worker doesn't know that they're talking about injecting. So yeah,
Exactly.
that's a good example.
Yeah, another brilliant example, yeah.
So Rhys, as a kind of final question, I wanted to ask you about if you had any kind of final musings or way, how do you see our gorgeous gay community going through modern times of hookup culture?
So yes, you sent me this question in advance, and I did have to have a little think, David. But actually, I remember thinking back to this this just guy I was just chatting to in a club. I won't name the club, don't want to name and shame. But we just chatting with a random guy. He was really fun. We were having a bit of a laugh, and he was this very handsome guy and very lovely branded clothes on. And I remember thinking, wow, this guy's incredible. Like, he's really funny, he's really nice, he's really great. And we've been talking about work, and he'd been asking me about, what I do. And I'd kind of talked about nursing, and he kind of voiced that he didn't actually really like his life very much, and that he very much wanted kind of what I had, and that he, wanted a career that was more fulfilling to him. He didn't have a sort of traditional career, and he wanted to have that kind of the sort of friends, the group of friends that I had, the group of friends I was out with. And it was a real kind of, I had to sort of think about it afterwards, and it was a real like personal moment of reflection for me, because it was something I very much needed in that moment, or excuse me, at that time. But it made me kind of realize that actually this man that I might walk past in the street and think he has everything, the looks, the money, he's, wearing these lovely clothes, and he's really
wanted by everybody. Yeah,
exactly. You might look at him and be like, wow, he's incredible. I'm not like that. I can never be like that. That's not me. And actually, he saw something in me that he was thinking, oh, I can't be like that. I can't do that. That's not me. And I think actually it's really easy to focus on the things that we don't like about ourselves and the things that we're jealous of or envious of in other people, when actually sometimes you just have to like stop and reflect on yourself a little bit. Even if it's like you wake up and you're like, I love my nose, I've got a great nose. My nose is fab. Even if you start there,
yeah,
having that self-love and self-respect and understanding that you are worthy and you are a kind person for yourself, but also for other people. That's seeing the good in yourself is better therapy than you can ever do.
I entirely agree. As a
That's not true. It's not better therapy than you can ever do. Sorry, David, that's not true. let me say that again.
No, because actually you're kind of right. Loving yourself, if you love yourself, you don't need therapy. What you're talking about is this inner critical voice that is so common amongst our community, because we were told we were less than everywhere we looked growing up, even fearful of not being good enough for our own parents, and their love might be taken away from us if they knew this dark secret we were having. And even if they understood and thought it was okay to be gay, they still might think the gay sex is disgusting because their God does. So I mean, there's so much affirmation that we seek, and you can get so much affirmation from a grinder compliment and from someone in bed, and you can actually live up to those expectations with the drugs. And I share with you that a lot of people I meet have that thing, and my heart goes out to them as yours does. You're a kind man, Rhys. I want to be like you.
No, stop it, David. I'd love to be like you. I'd love your flat. It's beautiful. Look at that decor.
It's a COVID overdone nightmare, but I love it. I really do. I just sink into it. It's my home.
Love it.
Rhys, let's talk again soon, and let's have coffee soon, because I miss you. Thank you for doing your amazing and important work. Mostly, thank you for caring so kindly for this community.
No worries. And, I work with incredible people in A&E. I've worked with incredible people with sexual health, and I'm very lucky at the positions that I get to be in today because of that. So thank you, David.
Bye.
Bye now.